principles of knee arthroplasty. After listening to wonderful talks on all aspects of knee, which have led down to this stage now. So knee arthroplasty is basically an end-stage procedure for a painful and arthritic knee after all other alternatives have been exhausted. And one must realize that it is primarily a soft tissue surgery with a few bone cuts thrown in. If you want a good result, you must remember that it is the soft tissues which you will need to respect. So before you decide to operate, you need to do some pre-op evaluation, which means proper patient evaluation and patient selection leads to proper results. One has to look into all the aspects of the patient, which includes his physical condition of the joint, his physiological condition of the body, his medical comorbidities, his financial status. Why I'm saying financial status is whenever you're going to do a knee replacement, do remember that this may not be the last surgery that you're going to do for the patient. There may be more to follow, and God forbid there are problems, you will have to have more financial support available. So one should not pick up a patient who has sold everything or somehow managed to get so much money to get one procedure done, expecting that this is the final assault. And finally, the social conditions. Knee replacement for certain social people in the villages, etc., has to be taken up with a lot of caution. Will they be able to use it? It is like gifting somebody a Mercedes and go and drive it in your fields where a tractor does the best. So, as I said, adequate examination we've heard beautifully before, and most importantly, before you plan a knee replacement, you must evaluate where is it tight, what are the deformities, what are the soft tissue issues, is it very lax or is it a very tight knee, like we heard the flexion deformities. And one thing which is so important, and I've often seen, the neurovascular assessment is often skipped. And that is what I meant when I spoke after the wonderful talk by Dr. Parag, that this must become a habit with everybody. You should not leave the patient till you have actually felt the neurovascular structures at the foot, because you might just one day regret being blamed for a problem which was already there, and post-surgery it flares up and becomes your problem. Now, what are the indications for a knee replacement surgery? Mind you, the only and main indication should be pain, 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 pain. Pain due to advanced arthritis, which could be degenerative, inflammatory, post-traumatic, and sometimes healed infective like tubercle. Pain with associated swelling. Remember pain. Pain with fixed deformities. Pain should be given sufficient trial of conservative treatment whenever possible before an irreversible procedure called knee replacement is carried out. The extended indications could include fractures around arthritic joints, unstable knees, often seen in post-traumatic situations, revisions of failed unicompartmental arthritis, post-high tibial osteotomies, and at times fused knees due to multiple causes. These all have their own way of doing them, but these are the extended indications. Let us complete the contraindications before we go further. The surgical contraindications are infection, especially ongoing or recent. People have gone on and bravely now looking at situations to do these in healed infections, but it is best avoided in the beginning. Isolated deformity or limb-length discrepancy. Now the patient sometimes thinks that when you operate, they'll get taller. They don't get taller because of the knee replacement. They often look taller because you have corrected severe deformity like severe varus, maybe a severe bow-leg situation, and both the knees get straight, automatically patient looks taller. Charcot's joints, we all know, are a recipe for disaster with replacement surgeries. Medical situations which contraindicate anesthesia, major surgery, morbid obesity is also a relative contraindication. These days you can go in for things like a bariatric surgery, reduce weight and then go in, but over 40 or 35 BMI, think 10 times before touching the patient. So in a nutshell, one has to treat the patient and not the X-ray. This is an elective surgery and not an emergency. And that is why you would have seen in this era of COVID, if there is one surgery in orthopedics which is minimized for the time being, it is knee arthroplasty. And the knees, how can they fail? They can lead due to loosening, instability, malrotation of the implants that you have put in, infection, which like any other orthopedic surgery, breakage of implant, you can see here, of the plate, fracture, and extensor apparatus rupture. Why I put this slide is this is about 20 years ago. I saw this patient when we used to make slides and not with the computer, but with the glass slides. This patient came to me and is the only situation where we had all these indications on the left to go ahead and try and do something. So what is the goal of total knee arthroplasty? For patients, they should be given realistic goals. Even a well-placed total knee will neither feel nor function like a God's given knee. It can come close to it, but you cannot say that it will be like that. Younger patients are advised about the abuse of a knee replacement, and older patients should recognize that reconstruction of a single joint alone may not alter their overall functional abilities. So they should not think that if you have taken care of their knee, their pains and aches in the shoulders and neck and maybe hip or ankle will also get sorted out. Now, this is very important for the surgeon to talk to the patient before venturing into the surgery. Radiologically, we had heard about this. The best thing to do is to take standing full-length pictures or scanograms. If it is not possible, you may take separate X-rays, but standing at least in the AP view and join them to get an idea of getting the biomechanics corrected and determine the biomechanical axis, that the anatomical and the mechanical axis is, before you venture into operate. We have heard about biomechanics. I'm going to cut it short, but you must know what is the mechanical axis, what is the anatomic axis, what is the vertical axis which runs through the middle, and the angles of 6 degrees from vertical axis to the mechanical axis and 9 to the anatomic axis. Similarly, on the tibial side, there is a 3 degrees of varus to the anatomical axis of the joint line. So what does that mean? Very simply, if you have a varus knee, your mechanical axis, you can see the line drawn, is going to be, this one, is going to fall on the medial side of the joint. And in a valgus knee, it is going to fall on the lateral side of the joint. This helps you to reconstruct in your mind that you've got to create a situation where this line comes back and runs through from the center of the head of the femur to the center of the knee to the center of the tibia at the bottom. So why must we achieve mechanical axis? Because if you get it right, look at this young girl playing on the swing, and you can see on both sides these kids, if they are balanced of the same weight, you will find that they will enjoy the swing. Similarly, if you want to enjoy the results, you should have uniform stresses acting on both the medial and lateral compartments. That's called a well-balanced joint. And in a well-balanced joint, automatically the patella will glide symmetrically in its groove. So you have a comprehensively a good functional knee joint. You can see here in the varus, if it's a varus situation, you will find the bigger arrows here. You can see the bigger arrows show that there is greater stress medially. In a valgus knee, there will be greater stresses on the lateral compartment. And if you have a good balance, there will be equal stresses. Now, the other important thing when you're doing this surgery is you must get the joint line where it would have been naturally back. This is more difficult in revisions, but should also be the aim when you're doing primary knee replacements. So in this, you must remember that the joint line on the lateral side is 2.5 centimeters below the lateral epicondyle. On the medial side, it is 3 centimeters or 30 millimeters below the medial epicondyle. And on the lateral view, you can see from the fibular head tip, it will be 1.5 centimeters above. One slide on templating. A lot is said and a lot is spoken about templating, but I have visited many places, and most places it is not used. There was a time when we used it so that we had to order 2 or 3 boxes of implants, one size bigger, one size smaller. So one would template and get those. But today, all people, most OTs have all the ranges lying. So where is the value of templating today? The value of templating today is like in the X-ray on your right side, which shows severe damage to the joint. It helps you pre-plan the restructuring and reconstruction of the joint and the deficiencies of the joint. Plan what kind of instruments and implants will you need in addition to the plain simple primary knee. So in this situation, it will be very helpful what kind of wedges, what kind of stems, etc. you will require. So templating is of value in complex situations and revisions definitely, but to get good at templating, one would suggest start doing it on primary knees also. So let's talk about the types of implants. Historically, there's a full listing you can read about, starting Swanson, duocondylar, but today the gold standard is the so-called total condylar knee. Now, these are further subdivided into cruciate substitution type or cruciate retaining type. The ones where the PCL is retained, the people who are proponents of this type of arthroplasty say that with this, the proprioception is better, means the orientation to space as the nerve endings in the PCL give the feeling of naturalness. There is a greater arc of motion. The PCL, when it is intact, we heard about the biomechanic talk that the PCL prevents posterior subluxation, intact PCL of the tibia in this situation. The stability is better. There is decreased interface stresses and shear forces are well tolerated. On the other hand, those who substitute the cruciate, like in this one, they say that in these situations, since you are removing the PCL, you need to resect less of the bone on the tibial side. There is a spine and cam mechanism which will basically work something like a PCL or will give the stability. It is an easier technique, and in more deformed or severely deformed knees, it is used, and many times even the cruciate sacrificing surgeons tend to use the substituting knee where the deformities and defects are very severe. And also to complete the range, there is the mobile bearing kind of knee where you have an insert which rotates on the surface of the polished tibia and the femur rotates on the top. The tibia lets it rotate on the bottom so that the mobility of this insert reduces constraint and prevents loosening of the bone cement interface. In addition, this dual surface articulation reduces contact stresses so that there is less wear of polyethylene and there is less osteolysis. There are arguments, but those who follow this, they swear by the results. So what is constraint? Least constraint is the cruciate retaining, then the cruciate substituting, then the varus valgus constraint, where you can see the cam and post are much bigger. And finally, the hinged type of prosthesis, which are actually locked with each other to provide stability. How do you do this particular operation? What are the basics of surgery? The skin incision used to be earlier a medial parapatellar incision, which was advocated by von Langenbach starting for any knee surgery in 1879, not knee replacement. However, gradually the incision has been shifted more laterally, keeping in also mind the vascular supply of the skin flaps. Now, most of the surgeons are careful to make this incision closer to the midline, but away from the most prominent part of the tibial tubercle. Otherwise, this scar could become painful. And if you're sitting on a table or your knee knocks against something, it can be excruciatingly painful. And also trying to take the scar away from the infrapatellar branch of the saphenous nerve, which can get caught in your incision and can form neuromas, which are terrible and which will make the patient forget about the arthroplasty itself, but remember the neuroma. So the medial parapatellar approach is, you can see, you can go down medially, straight down, and you go just leaving a little 1 centimeter or half a centimeter of cuff of the tendon of the patellar, hair of the patellar tendon, right down to the patellar tendon from the quadriceps mechanism. And this is for the reason that you can suture it comfortably later on. The important thing is that in the next step, when you have opened and gone right down, please make sure that you do not undermine the edges and go right down through the subcutaneous fat, because knee is essentially almost a subcutaneous organ or a joint. And if you do not go down straight, you can have a lot of skin breakdown and problems later on. So when you go down, you have a big blob of infrapatellar fat pad, which needs to be removed. Some people removed it totally. Some said we will hold on to it because it has vascular supply. But it was then decided that it would be the best to take it out partly. So just give me a minute, please. I need to put the battery charge. 1 second. Yeah, I'm sorry, I've been in 3 hours. So nonetheless, so then after removing, now partly removing the fat pad, you go on to start releasing medially. The subperiosteal flap is created going backwards. And in a cruciate substituting type, you then go and you can remove the PCL. But how to do that? Let's see. There are some other approaches for sake of learning for the postgraduates and younger people. The first one is the medial parapatellar. The second one is the subvastus. The third one is the mid subvastus. Then you have the lateral approach, in the end. Now, these are all different approaches used by different surgeons, but large majority use the medial parapatellar approach and are comfortable with it. Extensile approaches are there, like the quadriceps snips, VY inverted, etc. But the quadriceps snips does the job in most cases, and the cutting off of the quadriceps tendon or doing VY is now almost out of fashion. However, if there are situations where you feel you need greater exposure and you cannot get them in complex situations, and at times where there are a lot of adhesions or previous surgeries, then you may need to do a tibial tubercle osteotomy, which you need to take a large 8 centimeter by 1.5 centimeter. You take a window, elevate it, and then you need to put it back. It's in itself a technique which can be read in detail. However, going to the technical part and what are the precautions and care you need to take, you need to have the tourniquet, diathermy, and suction checked up before you touch the patient. There is no point fretting and fuming and shouting on the staff around you or your colleagues that one of these is not working. This is one of the simplest things said, but one of the most common problems. I said that go straight down. You can see there is no undermining. A medial parapatellar incision has been made, and we've gone right down to the joint, released the subcutaneously up to the periosteum. We have released medially, but also don't go too far back in the beginning. Only this further release of the deep part will be only done if required. Usually knees which are with so much fat and they are lax, they don't need to go too far, but the graded release is done depending on the stiffness of the knee that you find. The first step after opening up the joint is to remove the osteophytes all around the joint. And also note that Homan has been put at the back, and the advantage of that I'll just tell you shortly. The Homan is there, it's a blunt Homan, it has been put carefully, and the assistant who's doing this has to be somewhat trained and should know not to put too much pressure here. The tibia has been delivered forward, and you take the tibial jig. When you put the tibial jig, there are a few things to keep in mind. First thing you need to keep in mind that this jig is parallel to the shin of the tibia. Second thing is on the top, there's a mark on this, on the jig, which should be at the medial 1/3 and the lateral 2/3 of the tibia. The cut which is made on the upper tibia is made between 8 to 10 millimeters of the less worn out side. And if after doing that, there is still lateral on the other side, this is the medial side, on a varus knee, if you still find that you are having a defect, then that defect has to be addressed. You don't go around cutting further down to try and get that sorted out, because you will upset the joint line. At the bottom, you have clamps which hold the jig. And one way in the beginning is to draw a line which runs down to the second metatarsal, and then put your jig on the line here and above, as I told you, along the shin. Remember, in very severe deformities, especially in Indian patients, we note that the upper tibial tubercle position is not exactly correct. You may not work with the 1/3, 2/3 norm. But when you take these 3 points on the top, along the shin, and at the bottom, you are not going to go wrong. After that, you make your cut, which you can make through either the top of the jig or through the slot. I would recommend go through the slot. You will make less mistakes. At each step, there are ways of checking that you have done the right thing. In this step, you can actually measure with the caliper the thickness of the lateral side, which is the thicker or the healthier side. And if you put this across the light, you should be able to see the light going through the medial side, which means you have taken the least bone on the medial side and just the right amount on the lateral side. After you've prepared the top of the tibia, you measure the size of the tibia so that you know that this is what you will be doing shortly. All the time, this blunt Homan, which is angled, has been held by your more experienced colleague, not pushing it too hard, because you're not far from the neurovascular structures. Not only direct damage, but also neuropraxia or thrombosis can happen if you put too much force of the vessels. Then you come to the femoral preparation. And the first part of the femoral preparation is to make the entry point. To make the entry point, you go to the trochlear notch. From the center of the trochlear notch, you should be 0.5 to 1 centimeter anterior and about 0.5 centimeter medial. That will take you into the normal valgus angle, which is normal 5 to 7 degrees. So once you have made this drill hole on this side, you will then be inserting your intramedullary rod, on which you will put the distal cutting jig. Now this distal cutting jig, again, you can cut 8 to 10 millimeters. We are usually taking a 9 millimeter cut, as you can see here. 9 millimeter on both sides, which in lax knees can become 10, and in tight knees, we can consider it as 8. So both ways, it's comfortable, the cut. The other little thing, now you're making the distal cut here. The other thing which you need to be careful is when you're running this in hard aberrated bone, you may skive this blade and it may not be cutting properly here. So this is okay. And then when you hold this cut, you should have a very thin bridge between the two condyles. A thick bridge means you have cut too far proximally, and both separate is okay, better than a thick bridge, but ideal is a very thin bridge between the two condyles. sizing of the femur, and there's the next jig helps you size the femur, and it also helps you to put the jig or the next step in external rotation by 3 to 4 degrees. That is very important because with that you are going to make the cut on the posterior part of the femoral condyles parallel to the cut on the upper surface of tibia and get a perpendicular anatomical mechanical axis. So after this, the next step is using the AP jig. And with this, before you make the top cut, you use something called an angel's wing, which will make sure that you will not cut into the cortex of the lower femur, which is called notching. You will take off this, and this again you check for yourself. You see this cut is just correct because this is so-called the piano sign. If this cut leaves behind a surface which looks like the top of a piano, that means it's a correct and a good cut. Now you come to the condyles which you remove. You can see the medial bigger, lateral smaller one, and this is in a varus knee. And you can see the osteophytes, which here, the white one is the osteophyte. It has come out itself. Then you make the chamfer cuts with the next jig or with the same jig, depending on the system that you're using. Once you have done that, you use in every system, you have ways of sizing it. In this particular one, you have this a little jig with which you can measure the size of the next, the implant that you're going to put and the next jig. In this, I'm demonstrating a cruciate sacrificing type of a knee. And here we put the cruciate sacrificing block or the PCL cutting block. We put this, we make the cut, and here you can see now you've been able to make the cut, minimal bone removed, and the PCL has been removed with it. So this is a substituting type of a procedure. Then you can put these and see how much the medial one is bigger, lateral one, smaller piece from the posterior part of condyle. This is the notch cut, and this was the chamfer cut. After these all cuts, you can then use the spacer blocks to measure your gaps. In both flexion and extension, your gap should be equal and no more than 1 millimeter of opening on either side. 1, maybe 2, but no more than that. If it is opening more, then you need to correct your balancing. At this stage, you can put an alignment rod from the head of femur to the second metatarsal. How do you get the head of femur? Ideal is to put a ECG lead marker there, which you can palpate that, put this rod, and you've got your mark on the second metatarsal along the leg. With this, you will know where to put the tibial implant. That is the best way. You can then check the gaps also. Some people check them with laminar spreaders, but that can be fallacious. It's better to use the gap, the jigs that I had just shown you, the gap blocks. Coming to the last part, the patellar cuts, those who want to resurface the patella, it's your choice. There is still a jury's out what is better. We mostly do that. So we measure first the thickness of patella. If the thickness of patella is less than 22, 23, which means after your 7 or 8 millimeter cut, you are going to be 13 or 14 millimeters, you are okay to resurface. But if you are going to cut below that, then don't resurface the patella. If the patella is thinner than that and you resurface it, your chances of fracture on the table or later on in deflection are very high. So for that, you measure and then you take the depth for which you want to cut that much patella. Here we are taking 9.5 millimeters off. And with the cut through the slot, you get a nice surface. On it, there are different types of patella. Here is an anatomical kind of patella, which has 3 lug holes. You tend to medialize it a little so that you get good patellar tracking. And this patella is so made that the surface is such that it runs in the surface, the trochlear groove, almost anatomically. After you've done the patella, you put the femoral trial. This is the femoral trial. You put the tibial one. Now, there are ways to put, where do you put the rotation? Please make sure that neither the femur is in internal rotation or the tibia is internal rotation, because that leads to difficulties with your patellofemoral tracking. And you can see the ways to make sure is, one, you can come running down along the rod, along the mark you had made to second metatarsal, you're above mark, and the best thing you can do is called dynamic mark. You take away these things, you extend the knee, make a mark on with the jig here, with the tibial jig, and then you flex the knee, make a mark. And that is where the center of your true implant should be put. Make your lug holes for the femur, and you have put these two implants on the mark. You made 3 marks for 3 and put the center on the central mark, and you'll get your rotation right if you put this correctly. So before you cement the implants, you must check the movements, and you must see that the patella tracks nicely. The patella tracking is a crucial part of the surgery, often ignored and causes a lot of discomfort later if not checked at this stage. So now one question arises, should we do the femur first or tibia first? It is your choice, you can do any one, but if it is a tight knee, it's better to do the femur first. It will give you more space to work with the tibia. Otherwise, if it's a normal or a lax knee, tibia first is usually what most of the surgeons do. Basic bone cuts, one must keep in mind, when you're doing the upper tibial cut, it will affect the flexion space and the extension space of the joint. When you cut the distal femur, it will affect the extension gap. And when you cut the posterior condyle, it will affect the flexion gap. So flexion gap, both the gaps, and extension gap. So this is very important. And based on that, there is a sort of, you have a chart here, which you can actually put in your operating room, that if one is loose, the other is tight, what should you do? But when both the flexion gap and the extension gap are okay, then you're a great surgeon. And that's what you're targeting. Others, how to take care are very simple. You can easily get hold of this. And if you need it, please feel free to contact me. I'll send it to you with your email. Then you close. There are many ways of closing. Question is drain or not. Again, there is a lot of discussion on it. We use a drain for 24 hours. We have never regretted it. The only time we regret it is when we stitched the drain inside by mistake. So why I point out is that please make sure that when you put the drain, you do not stitch it. Pull it backwards for about an inch before you close. Closure, the most important part of the closure is the subcutaneous part. Then you tend to dress it, put your compression bandage, and rehabilitation. Finally, most important in rehabilitation is education. And education, friends, takes place before the surgery, not after the surgery. So your physiotherapist should ideally teach them well before they get admitted, or at least the day they get admitted, they should run them through all the exercises. Ideal is if a patient is waiting for surgery, teach them physiotherapy. They keep doing it before they come to you. Then they should be taught active range of movement, which is more important to build the quadriceps, especially training, gait training and ambulation, muscle strengthening. All these are part of rehab. Functional and activities of daily living training are the ones which they focus on rehab. This is our Arthroplasty Group, and I'm grateful to my whole team, especially to Dr. Chandeep, who's helped with this. Thank you for your kind attention.